Hello, welcome everyone to this afternoon session. My name is Henrik West, and I'm a professor of clinical microbiology at Hvidovre Hospital, a couple of miles from here. And I have had a very, very long interest in STD, so I'm really looking forward to this meeting, this symposium, STI testing in the next decade, organized by Hologic. And let me give the word to Siri.
Yes, thank you. I also greet everybody on behalf of ECCMID, and I hope we will get new insights into very pressing themes of the present. I'm the ECCMID appointed chair. I'm part of the educational subcommittee and leading the infectious disease department at the University Hospital Tübingen. So with this, I would kind of like to hand over very short-handed to the first speaker, who is Carsten Thiemann from Germany. He is working at Labor Krone and has an interest in STI in times of PrEP. So the floor is all yours.
To this symposium, and thank you to the organizers giving us the opportunity to present some data and to discuss afterwards. High-risk population, STI in high-risk population, I'm going to talk about the study situation over the last few decades, not too much from a scientific point of view, so I will not go too much into detail of the data itself, but more a general view on the studies we have had over the past few years. Why do we need studies? It's a very simple question with simple answers. I think it's obviously to improve our knowledge, to optimize and develop new products, strategies and concepts. And if you look at the last 3 years, we all know that a lack of knowledge might cause some misleading concepts and strategies. We have seen that during the pandemic sometimes, and if you have had 10 scientists in a room, you have 20 different concepts and opinions maybe. So this was a problem sometimes. So if you're going to organize a study, you start with a hypothesis or a question like what about the prevalence and what about influencing factors and what about biological factors? And you, based on this hypothesis and questions, you can construct a protocol with given risk factors. You would like to implement behavioral factors and so on and so on. All of you know that. And at the end, you have a protocol which includes a test population, a cohort. You can decide which sample type you use, and you can organize your analytical steps in the wet lab, for example. Afterwards, you have the data. You can construct the analytical step on the data set and do the evaluation and verification, and afterwards you have the conclusion. And whenever you have a conclusion, the result is, in almost all cases, a new question. So this is the cycle that goes around and around and around, and we can see what we have done in the STI area over the last few years. Just a bit off topic, last week I just tried to find out how many citations for specific phrases you will find in PubMed in 2 time blocks, around about 25 years from 1975 to 2000, and from 2000 to 2023. And as you can see here, if you have the classical phrases for STI like chlamydia trachomatis or STI prevalence, CTNG, in some cases you will find just a small number in the first area of this time frame, and increasing, but not too much increasing amount afterwards. But if you look, for example, here for COVID, you will find none citation up to 2019 and above 350,000 just in 3 years. So if you look at these data, it's not a scientific evaluation, of course, but you can see it's always a question of prioritization. What is needed and what is important, and what do you estimate as important and as a need? So, and STI is, compared to COVID, not too much in the focus, at least in the last 3 years. And if you look in the former time frames, in a time frame, for example, for this publication I found from 1985 to 1992, and a second block 1996 to 2002, they have investigated around about 1,000 women from the sex working field in London. If you look at the amount of samples they have, or participants they have investigated in both of the different time blocks, it's quite low. It's just 400, roughly 400 samples in each time block. And this is, compared to studies we run today, really a small amount of samples, but it is as it is. At that time, it was really hard to get the samples, and it was not so easy in the laboratory to analyze all the samples with a lot of different genetic, bacterial and viral targets. And also for Mycoplasma genitalium, which is more in the focus right now than in the past. There were already studies in the area in the field of MSM. And also here, they already investigated first what urine and swabs, rectal swabs, but also the sample amount was not too large. So it was possible to organize everything very easy, and also the evaluation of the data was not such a challenge because the data set itself was quite limited. In 2010 to 2030, together with the German CDC, the Robert Koch Institute, we started a pilot study using two different branches. The first branch was a subset of participants coming from a public HIV counseling institution, male and female, and the second branch was a hard-to-reach population, sex workers in an outreach setting. So, and we directly decided a short time frame and a higher sample number to enlarge the data set. And we also added a questionnaire to add the analytical data from the wet lab together with metadata. With metadata, I mean it's the age and the female, but also the sexual contacts and the educational status, the place of birth, and so on. This is what I mean if I say metadata. And we had women, especially in the outreach area for the sex workers, about 49 different nationalities. Together we had 3,329 specimen samples, and together in both branches round about 10,000 data points. But this was just the analytical data point, so everything which comes out of the wet lab. And additionally, we had a self-sampling system and was using illustrated instruction that the people who were involved in the study, the participants and also the street workers, were able to teach how to collect the samples in a self-sampling setting. And we also constructed electronically readable data sheets to add the metadata, to ask for additional metadata. So this is what you have. It's not only the calculation of a prevalence regarding the sample specimens, but also you can include the metadata, and you can combine the wet lab data with the wet lab data with each of the different factors from the metadata. So you have a broader variety of options how to investigate and analyze your data set. And this is quite the same. This is what we found, the content of different information we obtained from those sheets. I will skip a bit faster through it because I will come to similar studies later on. So this is what we found in the sex working area. So all the information were additionally available. And this slide is what you can see if you just have the wet lab data available and combine it with the gender, female and male. It's very simple, and you will always find it in any kind of publication if you have such a study. And you can combine the different branches. Also very simple. It's just the calculation of the prevalences based on the data from the wet lab. But if you combine it with the metadata, in this case, in this study, the data set was combined and evaluated, and the table which results out of it is somehow more complex. So we entered in a second study, the screening MSM in Germany, to investigate the prevalence in this group for chlamydia, gonorrhea, and mycoplasma. at different anatomical sites. So it was not just one anatomical site for the swab, it was 3 different sites. We investigated all the 3 sites for this 4 different STIs, also using self-sampling, questionnaire, and different sites in Germany, and collected also the metadata. And as you can see here, this is a study population, 2,300 MSM, samples collected within a year, 1,100 HIV positive, 741 HIV negative and non-PrEP users, and 283 HIV negative and PrEP users. So also additional metadata which you can include in your evaluation. And as you can see here, this is the normal prevalence presentation, just spread it out for the different anatomical collection sites. And if you include all the metadata, you can enlarge the evaluation in several different ways, and it makes the evaluation more complex and takes more time to combine every different information you have with other information that makes sense. For example, infection by STI, infection by anatomical site, the content of symptomatic STI by localization, and so on and so on. So the more information you have, the more complex the evaluation and the presentation of the data will be, and you can also calculate different risk factors. We've done that in the NSMS and MSM screening study as well. And as you can see here, different risk factors by age, the risk by clinical symptoms, and also, for example, here, the highest risk is anal intercourse without using safer sex. I wonder if you need really a study to find this as a risk factor, but it was clear, demonstrated in this study that this is really a risk factor. So as you can see here, it's really a challenge to combine everything which makes sense and to exclude everything which does not make sense. So last but not least study, the BRAHM study was comparable to the screening MSM study, and it was again enlarged by additional information that have been collected. The first was we just choose sites, cooperation sites in areas which high HIV prevalence. We decided a specific recruitment using different questionnaires, different visits, not only one sample collection, but several sample collections over time. In total, 6 visits in a time frame of 12 months. And also different anatomical sites for collection. And we enlarged the panel of the STIs, not only these 4 we have in the former studies, we've seen in the former studies, but also HIV, hepatitis A, B, and C. So we also used a blood sample and a questionnaire as well. So this results in total in just 188,000 analytical wet lab data points, not including the metadata from the questionnaire. So for this, it was absolutely necessary to have a specific workflow for the sample management, a specific digital workflow for the data management, and also a workflow for how collaborating with each site, with each partner in this study. So this was quite a challenge, and you have to prepare this very carefully to be really in a good shape. So as you can see here, I will skip that very fast. The number of different evaluation and analytical options from the total data set is really huge. And we are just at the beginning of the BRAHM study, I mentioned now. And as you can see here, these are data taken out of the first paper we have written, and the analytical work is still ongoing, but limited over the last 3 years because of the missing resources just to analyze the data. So this is a presentation, and the last study I will mention here from the STI side is a STIPNet study. It's quite the same as the BRAHM study, and again we enlarged the data set by not only using or asking participants from Germany, but asking participants from different sites in different European countries. again, different STIs, blood collection, as well as swabs from different anatomical sites. The plan is, because every samples from all those studies have been stored in our archive, so the plan is afterwards maybe also to analyze in a multiplex setting additional STIs like the herpes viruses and others, and for example, Trichonema pallidum and others, Trichomona, the trick. And we have also dried blood spots for medical treatment level detection. So again, this, as you have seen that from the BRAM study, and this study results in 635,000 analytical data points, just the wet lab, and additionally, all the data from the questionnaire. So this is just a brief analytical thing we did during the last few weeks. It's full of mistakes. It's not the final evaluation because we have never the chance to analyze those data. The STIPNet study finished September last year, and no one was able to look at the data right now. We just took a brief look at it, and you can see here the number of participants per month, and you can see here the early phase of the pandemic in 2020, and nobody knows, because we have so many information from all those participants and visits, if the pandemic has influence on the results later on. We will see that maybe. So as you can see here, we lost, for example, from the first visit to the second visit, we lost about 1,000 participants. We've never seen again after the first visit. And in the total subset of samples, there was just 1,500 participants that have used all the 5 visits. So you have to be very carefully if you put everything together, like this slide. You put everything together, sum up every positives and negatives, and you will have such a table, and this table might let you go to a totally wrong way, because you have combined every data you have to evaluate, to find out the correct information and to draw out the correct conclusion out of it. And this is not that simple as it looks like. So it's not helpful to present data like this. It's just a sum up of the positives and negatives. Putting everything together, and do not reflect that all the metadata also have an influence on the quality of the data. So just to show you the last point here from the data set, as you can see here, you have some countries with a very good distribution of the sample taken per year. Here, and for example, in Italy and Poland, and in Spain, for example, they started a bit later, and almost all the samples have been collected in 2021. So you have a European sample cohort, but if you look at the data itself, when they have been collected and what the story behind is, also this might influence the result interpretation, and we need systems that are able to identify all those different drivers to have a good and quality conform information. At the end, the last slide before I come to my conclusion and my remarks is we were asked to determine the immunity against SARS-CoV-2 in the German population, in a representative German population, and the time frame was 6 months. That comes from the government. And we organized that just using digital recruitment, digital questionnaire using the internet, self-sampling by construction of a self-sampling kit, and using postal services for sending and resending, digital result report, and digital counseling. So everything during the whole study, no one has seen the participants. And the invitation was just in May for about 28,965 participants. The sampling time was June to September 22, so just a time frame from 2 to 3 months, 3 to 4 months. And we were able in that short time frame to include roughly 16,000 patients, and we were able to estimate and to calculate the immunity against SARS-CoV-2 in a representative German population just in a time frame of 4 to 6 months, including everything. So this was really a challenge, but you can see it's possible. So my conclusion, coming out of all those data and slides, The digital tools like online recruitment and online questionnaire simplify the organization of large studies. So it would be possible in the future to create a large data set which in a very short period of time. And also the new sampling strategies will reduce the fear of contact. It's very using digital systems that we have seen in the guide study for the antibody detection for corona. Reduces the fear of contact of the participants because you have home sampling options. The new automated technologies allow you to handle a huge number, tons of samples per week or per month to be analyzed in a short time frame. And you can create a large data set, but this will require new technologies for evaluation because as we see in the SIPNet, there's no human resources available to evaluate this in a very short time period. And it results in a data collection and construction of a data set within, let's say, 6 months. And an evaluation phase of, let's say, 2 to 3 years. And if you have the final evaluation, you are in 6 years or 3 years after you have measured all your data. And the question is it still relevant if it takes so long to evaluate all the data? So finally, my personal remarks, and due to the new technologies, the overall number of analytical data points will increase dramatically. Especially if we include multiplexing, and we never talked about NGS or the whole genome data we also have. We've learned that from corona have to be interpreted. The metadata are also very relevant and have to be added to the analytical wet lab data. So we need bioinformatics, we need biostatistics, and maybe we need self-learning computer systems, artificial intelligence. We need something like that to be included in our data evaluation because otherwise the data set is so huge and we were never able to find out the very important information out of this huge number. So the more complex the data set is, the more important also is the quality management and quality control, and a dense control of the post-analytical steps is really a need. So this is the last slide of my presentation. And of course, I have to thank a lot of people that would I would be really out of time if I thank everyone, but just the company Hologic, of course, especially Thomas Schellhorn, Christian Stöckicht, and Tom Osterlaken from Hologic that enabled us to run all the different studies, all the people, partners in national and international sites, Hendrik Streeck, as principal investigator of the STIPNet and BRAHMS study, and last but not least, all the participants who spent all the samples to be analyzed. This was my last slide. And to be honest, I would prefer to have more comments than questions, because I would expect I can never answer your question, because it's really a specific question we have to answer all together. So I would like to have some comments. Thank you very much.
So thank you, Mr. Thiemann. That was really impressive, and I am looking forward to seeing how you will deal with this amount of data. We have room for one comment, as you said, comment or question. So maybe I could ask one question for the last study. You said you had longitudinal sampling, and did you include metadata-wise treatment? And if so, did you also do susceptibility testing?
Yeah. The testing is still ongoing, but in the questionnaire we ask for clinical symptoms, for treatment, effect of treatment. So the study itself was also to have a kind of test of cure. So, but it's all in the data, but right now we have not looked at that. So unfortunately, it's really time consuming. Yeah.
I can imagine that.
Thank you.
So again, thank you very much for this interesting data. And I would like to welcome Jane Schwebke from the United States. So she is a professor of medicine with a joint appointment in epidemiology in the University of Alabama, and serves as a medical director to the Jefferson County STD Clinic. And we're looking forward to your talk.
Thank you very much. I was told I only have 25 minutes, and since I wake up in the middle of the night thinking about vaginitis, I had to really work to limit my talk to what I thought were the highlights or new things that have come up. These are my disclosures. So I limited my talk to the most common infectious causes of vaginitis in the reproductive years. And that, of course, as you know, is yeast, vulvovaginal candidiasis. Whoops, heavy finger there. Oh, sorry. Trichomonas, which is everybody's favorite because they're so cute. They really are. And bacterial vaginosis, which is kind of my favorite because I really don't know half of what I should know about BV. So having grown up in the microscopy age and I just pointed out how cute Trichomonas was, so you know I love microscopy. Now we are in the gnats age, and that has become the gold standard. So I had some thoughts about what this means to what would be my clinical care of patients. We do know that the way we've been diagnosing vaginitis in the past has been inaccurate, especially if we just say hi to the patient and say, oh, yeah, you have yeast, which is what happens a lot, at least in the US, among practitioners. In my experience, there are very few centers or practices that really do high quality microscopy. So to have something like gnats testing, which is very specific and sensitive, I think is definitely an advantage. And that's what I was said in this wet prep. The other thing about wet prep is that it can detect mixed infections. So that kind of helps you at the time. And of course, it's immediate. You have the result you have and can go to the patient and give her an accurate diagnosis and accurate treatment. gnats testing, highly sensitive and specific for, we now have Candida, Trichomonas, and BV, and it can detect mixed infections. But I'm concerned about the turnaround time because I'm not sure what I'm supposed to tell my patient who has come in there and wants her treatment now. So I'm not sure how people are going to balance that. Hopefully the woman, I doubt it, but I hope she'll be patient and wait for the phone call the next day, but I'm not sure. And then I should have clarified this last statement. It's only licensed for symptomatic infections for yeast and for BV. For Trichomonas, it is licensed for screening. So that was a little bit inaccurate on my part. And then the other, always cost enters into an equation. So what's new with yeast? Not too much. There are, if you can tell, that's my least favorite. But anyway, there are two new drugs that I guess you should be made aware of that have come out just very recently. One, and this is a mouthful, is a new class of agents, and it's ibrexafungerp. And it has activity against resistant strains, including glabrata, so that's very helpful. It has good penetration into the vaginal tissue, a very favorable safety profile, some GI side effects, and is licensed for acute and recurrent VVC. However, it is stated that you should not use it in pregnancy. The other molecule is oteseconazole, which of course is an azole. And again, it appears to have activity against Candida glabrata. This is a question that comes up a lot, although in my practice, Candida glabrata was not that common. It has good tissue penetration. Azoles, of course, have the potential for fetal malformations. We've seen this with fluconazole. It has a good adverse event profile, and it is licensed for recurrent VVC. However, it is only licensed for use, and this is in the US, and I apologize if there's differences in Europe. It's only licensed for use in postmenopausal and sterile women. So for the run-of-the-mill young lady with vulvovaginal candidiasis, that may not be helpful. So that brings us to the use of fluconazole. And as I mentioned, fluconazole also has been associated with fetal abnormalities, so it shouldn't be used in pregnancy. But as opposed to the compound I just told you about, oteseconazole, its half-life is not as long. Oteseconazole has a very long half-life, and I think that's what led the FDA to be very concerned about its use in pregnancy. Fluconazole can be used weekly to prevent recurrent VVC, and this was a study that was published years ago by Pfizer, but they never went for the indication for recurrent VVC. So I'm not sure here. I imagine that in Europe this is used a lot because I was told that fluconazole is OTC in Europe. In the US, though, it's amazing to me how few OBGYNs know about this weekly regimen. But anyway, it can be used weekly to prevent recurrent VVC. You have your usual things, don't use during pregnancy, beware of hepatotoxicity, drug-drug interactions. And usually when we use it for recurrent VVC, we use it for 6 months, then stop and kind of reevaluate where the woman is there. Okay, moving on to trick. So, what's new with trick? This is an ancient slide from the CDC, absolutely ancient, but it still tells the story of what goes on with STDs. And you can see that trichomonas is right up there, the poor ignored trick. He's there. So, very common. And then the other thing to realize, and this is also an old slide, but this has been validated by recent studies that looked at NATS testing in different age groups. And the interesting thing about trick is that whereas gonorrhea is higher, prevalence is higher in the younger age groups, trichomonas is pretty steady throughout the age groups. And we find it to be very common, actually, in older women. Why this is, I can only speculate that before we had widespread screening for trick, and in some places we still don't, there was really no control program, if you will. So there was no way to try to get this infection under control. And many cases are asymptomatic, as you know. So that's my thought on that. But I think we need to keep in mind that older women can have this problem as well. Now, I mentioned the wet prep and how in love I am with it. I even have a microscope at home. But I think we need to realize not only do you need skill in identifying pathogens with a wet prep, you also have to be pretty quick about it. This was a nice study that looked at the survival rate of trichomonas in wet preps over time. And you can see there's a very nice linear decline. The longer you wait to look at your wet prep, the less likely you are to find trichomonas. And even if you look at it right away, as I mentioned, the sensitivity is probably, it depends, probably 60%, maybe 80% if you're really, really good at it. So I like the wet prep, but it has its limitations. Okay, well, what about treatment? Well, treatment, not much to say here, except that the CDC STD guidelines that were published, I guess about a year ago now, maybe more, time goes fast, replaced the stat dose metronidazole with metronidazole 500 BID for 7 days. Due to a recent clinical trial by Kissinger et al. That found that the 7-day regimen was superior to the stat dose. So that's been a change. I'm not sure everybody has made that change yet. Of course, you're giving up convenience and potential compliance issues with going with the 7 days, but the study did show that it was superior. Of course, we should always treat the partners. And this is sort of the conundrum for me because we're giving her 7 days, but we're still giving him a stat dose. So I'm not sure what that means. And something that I found out late in my career, which I should have known and would have helped me design a better study, was that there's this spontaneous resolution of trichomonas in men. So about 50% of the time, they will just, it's gone, which I think is, it's so interesting and it's so relevant if you're designing for study designs. But if you think about it, it's really not too hard to understand. If you think about Trick living in the vagina with all those goodies around for it to munch on, and then you think of Trick living in the urethra, which is kind of a desert, I can understand why it wants to get out of there. So keep that in mind. Alternatives, of course, other imidazoles, tinidazole or secnidazole. Secnidazole, I think, has been in Europe forever. It was recently licensed in the US. For resistance, and I have come across several women with this problem, and it's a terrible problem. If it fails routine dosing, if she fails routine dosing, you can try tinidazole or metronidazole for even longer periods of time. What I have found that works best in the women that I treated was a regimen by Paul Jesse, which was a combination of peromamycin cream, vaginal cream, plus 14 days of high-dose oral tinidazole. I mean, it's a tough regimen. Peromamycin can cause vaginal irritation, so you have to warn the woman about that. And high-dose tinidazole, I mean, can be tough to take, but I have had success with that. We all know the complications associated with Trick, and these are similar complications that are associated with BV. Speaking of which, here we are, our clue cells. Well, clue cells have become more interesting to me because now we know, and I'll get to this in a minute, what clue cells really are. And I love this quote. This is very retro, I know. But I was converted. I was converted from the polymicrobial theory to the Gardnerella theory. So I'll warn you right now. But I think it's really interesting. And this was a quote from Gardner and Dukes years ago, 1 year after I was born. We are prepared to present evidence that the vast majority of so-called nonspecific bacterial vaginities constitute a specific infectious entity caused by a single etiologic agent. We have assigned the name Haemophilus vaginalis to this newly isolated bacillus. And as an infectious disease person, I think that made me come to this, that I can't think of too many infections that are caused by, yes, we have polymicrobial infections, but really, let's think about STDs. It's one pathogen. So this would fit in with what we know about other STDs. This may be difficult to see, and I apologize. This was a study by Katarina Bradshaw in Australia, and I thought it was an interesting study because there were a lot of studies already out there that showed that the most significant risk factor for incident BV was sex with a new partner, a new male partner. But her study I thought was fascinating because the most significant risk factor for recurrent BV in a woman was sex with the same partner, which to me gets to this ping pong thing. You know, okay, I treat her, she gets better for a week, now she's not better anymore. Well, maybe they're passing it back and forth. In terms of the microbiology, you all know this, marked decrease in lactobacillus species, the good guys. GVAG is uniformly present in high concentration in women with BV, and in fact, the NATS tests, some of the NATS tests, they all have different algorithms, but some of the NATS tests rely on a concentration effect for GVAG. And there's an abundance of strict anaerobic species, which is interestingly heterogeneous between individuals. And here we get to the clue cell. Dr. Swidzinski, what a paper. I mean, I almost fell off my chair when I saw this. But what you see here is the proof that BV is biofilm. It's a biofilm infection. And the orange probe is for Gardnerella. The kind of greenish probe was for lactobacillus. But you see this beautiful, continuous row of GVAGs there. And so now we know that clue cells are the sloughing of the biofilm. So I find that to be very interesting and very pertinent for how we may approach treatment of BV, because let's face it, we have terrible treatments for BV right now. So another thing that was brought to my attention by my mentor years and years ago, and I should have listened to him then, but I didn't. And again, I only thought about this more recently, are the similarities to periodontal disease. And if you pick up a textbook of I don't know what you call it, dentistry, oral health, whatever, they have beautiful diagrams and beautiful prose about the fact that facultative anaerobes, which are aerotolerant and proteolytic, perform the initial reduction of available oxygen, which the saccharolytic species need. And this lowered redox potential is then the primary selective pressure for obligate anaerobes. So what am I talking about? So facultative anaerobes would be GVAG, and then once it sets up the environment, you can have the proliferation of strict anaerobes like Prevotella, Mobiluncus, such as those. Now, this is a study, and I never met Dr. Pybus. I wish I had, but it's an older study. And again, you know, I don't think we pay enough attention sometimes to what's been done in the past. And this is really beautiful, I think. And here we see this cycle where GVAG is proteolytic, producing amino acids, versus lacto, which is saccharolytic, and utilizes glycogen and produces lactic acid. So in this cycle, you've got production of an increased pH and a decreased redox potential, which is, I feel, what's going on in BV. This is very complicated. I'm sorry, but I'm really proud of it anyway. This is a conceptual model of what's going on with BV. And we actually start with, I wish I could walk. We actually start with both the birth of the female and the birth of the male. And we take it through all the steps. And just to sort of reiterate, we feel that the male is that it is sexually transmitted, and that it is following those metabolic cycles that I've just described, and ends up with the production of BV. So what about GVAG in males? Well, there's lots of studies out there that have looked at this. Gardner and Dukes years ago isolated GVAG from over 90% of male partners of women with BV. Dr. Hillier was looking at semen samples from infertility clinics and found GVAG and anaerobes from asymptomatic males. Peter Piot, who went on to great things, looked at biotypes of GVAG. This must have been his project when he was a fellow in Seattle, I think. And I isolated from women with BV and the urethras of sex partners, and they were identical 90% of the time. And then we did a little study where we looked at our STD clinic population and looked at GVAG detected by PCR and found it in 25% of our men attending the STD clinic. And I should mention that in our STD clinic in Birmingham, Alabama, about 50 to 60% of women have BV. So just the last couple slides. These were a couple of more recent studies that we did, my team, to try to get at some of the answers to the questions that I still have. So this was a study where we took women with recurrent BV and enrolled both the women and their sex partners, their male sex partners. The women were treated with a week of metronidazole, and the partners were randomized to either a week of metronidazole or placebo. It was double-blind, blah, blah, blah. And we looked at what happened. Unfortunately, my hypothesis was, of course, that treating the male partner would result in decreased rates of recurrent BV in the female. Well, it didn't. But there was some interesting data that came out of this, I think. And if you look at these graphs, you see that, and I think this didn't come out quite right, but I'm sorry. If you look at the white bars are, they did not use, the white bars, you see they have a limited percent that used condoms. And also lesser amount of treatment adherence, and that was by the male partner. Whereas if the gray bars represent condom use with the regular partner, better treatment adherence with the regular partner, and the black bars indicate good condom adherence, I should say, with all partners, and good treatment adherence with the male partner. So I think that there is some message in here. We work with a very high-risk population, so I can't, control for reported use of condoms or sexual activity, et cetera, et cetera. I think if these studies were done in a more controlled environment, we might see a difference. And then lastly, since I'm a fan of GVAG, GVAG can be found in women who don't have BV, and that for years that's been touted as a reason to dismiss GVAG as a pathogen. But there's lots of instances in which the causative organism is present but doesn't cause overt disease, and I give the example of salmonella, for example. You can be a carrier and not have overt disease. So we designed a study that would have been like a first step in looking at treatment of Gardnerella to prevent BV. So the pilot study was to determine if amoxicillin, we used amoxicillin because it has very good activity against GVAG, but very limited anaerobic activity. It was designed to see if we could treat women with amoxicillin and eradicate vaginal colonization of GVAG. Again, as a first step in determining if eradication of GVAG colonization would prevent BV. Again, it was a negative study. There was no difference between amoxicillin and placebo in terms of colonization rates of GVAG. However, none of the participants in whom GVAG was eradicated, and we tested this by PCR, in whom GVAG was eradicated, none of them had abnormal vaginal flora at follow-up, day 21. All of those women had a Nugent score of 0 to 3, as opposed to the other group of women in which GVAG was not eradicated. There was a statistically significant difference. So again, I think a little clue that might be built on in future studies to help answer some of these questions. So that's all I have, but I hope that there's questions from the audience. I want to thank you very much for your attention.
Yes, thank you for this very interesting talk. Are there any questions or comments?
Oh, certainly somebody must think I'm crazy for wanting GVAG to be the pathogen.
Maybe I can fill in the time with a clinical question. As you pointed out, there are women that are asymptomatic carriers of Gardnerella vaginalis. And are you aware of any protective factors? Is it always the same women that are carriers but do not get asymptomatic, or can this occur in one woman?
That's a great question, and I'm not aware of any studies that have looked at that particularly. I mean, I guess you could hypothesize that the greater the number of exposures maybe would increase the concentration of GVAG and lead more frequently to BV. Or other people have hypothesized that there's different genotypes of GVAG, some of which may be prone to go on to develop BV as opposed to other genotypes. We actually did some preliminary work with that, and we didn't publish it, but we did not find a trend. But others, I think, have published that data. Okay, thank you.
I have a single question, yeah. So do you think there's a role for the rectal microbiome? Maybe the rectal microbiome.
Oh, the rectal microbiome. Yeah, a lot of people have hypothesized that. No, I don't think so. I think the vagina is the vagina and can protect itself despite whatever. I should say, though, I do want to add one thing that I should have said, because I mentioned that knowing that this is a biofilm infection should help us develop better therapies. And I think that's important because I see that if I was developing drugs for BV, I would use a combination of a biofilm inhibitor and an antimicrobial, such as nitroimidazole. But I do them together because you've got to get, if you have that big biofilm sitting there, those bugs are going to say, you know, bring it on. I don't care. So I think we have to disrupt the biofilm in order to get the treatment to work.
Okay, we're kind of running out of time, but there's two persons in the audience. Actually, I'm sorry, there was this lady in front who was before you signaling. Do you want to step up to the microphone or just speak out loudly?
Well, obviously with trichomonas, that's a problem. With BV, I mean, I personally think it is sexually transmitted. Does it have a spontaneous resolution rate in male urethras, such as trick does? It may. In fact, there was an old study by Elizabeth. Oh man, help me. She was from Sweden. Anyway, who looked at that. It was a very, very small study, but she looked at men who had urethral colonization with BV bugs and then had them abstain from sex and sampled them. This was by culture. Sampled them, I don't know, a week or 10 days later, and they were gone without treatment. So again, I think it's just not a very hospitable environment. So I think it has a lot to do with when you have sex and who you have sex, yeah.
Okay, we are running out of time, but one short question and short answer.
Dr. Jane, what is your experience in cases of badly recurrent BV for boric acid suppositories and local long-term metronidazole gel? So does those two interventions work with that category with ladies with having very bad recurrent every 2 or 3 weeks?
I'm not sure what the second question, second...
The option is the metronidazole gel. So
metronidazole gel.
Some experts do recommend that to apply metronidazole gel 3 times a weekly for a long time for some physicians.
Yes, that's right. So metronidazole gel has been shown to be protective against recurrent BV. And boric acid is sort of a biofilm inhibitor. So I think that could have benefit for women who have very difficult to treat BV.
Okay, thank you very much. So we will welcome our next speaker, which is Melissa Kaza from Canada. Please step up to the floor. So she's a researcher at the University of British Columbia and a scientist in the molecular microbiology laboratory at Kelowna General Hospital.
Well, thank you very much for having me. Today I'll talk about the evaluation and implementation of the molecular assay for diagnostics of vaginitis. These are my disclosure, and today I'll talk a little bit of the background of vaginitis, although it was beautifully presented by our previous speaker. I'll review the retrospective study results that we did in our lab system, and I'll give a brief summary of the implementation process for interior health. The background. So vaginitis is a very common disorder presenting for women at their primary at their healthcare provider. This is really crashing. So vaginitis is presenting, women present with vulvovaginal discharge. They have odor and pruritus and also present discomfort. There's infectious cause or non-infectious cause for vaginitis, but today we're going to focus on infectious causes. Bacterial vaginosis, Candida vaginitis, and trichomonas are the most common ones. And traditionally, the EMSIL criteria are the diagnosis, but in clinics, but now providers, healthcare providers rely on lab-based diagnosis. We did a study in interior health, which is in British Columbia in Canada. And we also did in partnership with Vancouver Coastal Health. It was a 2-phase study. The objective of the first phase 1 was to evaluate the performance of the Aptima BV and CVTV assays compared to conventional testing. This phase was also this retrospective study was done at Interior Health, but also in Vancouver Coastal Health, and this phase has been completed, and these are the results that we'll talk about today. And phase 2 is a prospective validation study that was done in the STI clinics at Vancouver Coastal Health. It's also ongoing. So, like I said, it's a retrospective study. We did evaluate the women's specimens from women of reproductive age were collected. And these women had been, the specimens from these women were tested for chlamydia and gonorrhea and also BV at the same healthcare encounter. And and then we did collect the samples from March to October 2021. We did that in the Interior Health at the Kelowna General Hospital, and we basically banked the CTGC multi-test swabs and also the gram smear and the e-swab for that we use for BV and also yeast, and we banked all those specimens. And then, and we used for resolution of discrepancy, we used the conventional swab that were frozen at -80, and we also kept the gram smear slide, so we were able to go back. For the yeast, all the specimens that we use in the study were cultured. Typically, they were not. But for this study, we cultured all of them. And we were missing some of the species. Oh, it's working now. If we were missing some of the specimens, we did use contrived specimens to create a bit more variety in our for our validation purposes. Okay, now this is not working anymore. I suppose this is working. Okay. Conventional testing methods in our lab system, we use gram smear for BV, and for this specific for the study purposes, if we had a Nugent score of 0 to 3 or 4 to 6 without clue cells, we did consider the results BV negative. If the Nugent score was 4 to 6 with clue cells or 7 to 10, the specimens were considered BV positive. We use yeast culture of the e-swabs and the MALDI-TOF to identify any species, any growth and speciation. And TV was detected by molecular, is detected by molecular, the Aptima TV assay. Okay, so now I'll talk a little bit about the Aptima vaginitis assays. The Aptima BV assay and CVTV assay are approved for diagnostic in Canada, US, and also European countries. These are TMA, real-time TMA assays. Aptima BV, and also they use the same multi-test swabs as it is for CTGC. So it requires very little hands-on time to put it on the Panther instrument. So Aptima BV assay quantify Lactobacillus, Gardnerella, and Atopobium. And it it has a proprietary algorithm that produces qualitative results for BV, such as positive or negative. The Aptima CVTV assay detect the presence of Candida species, Candida glabrata, and also Trichomonas vaginalis. And also it produces a qualitative results for each of these targets. I want to introduce here the second molecular assays for resolution of the discrepancies. We use the C-gene all-plex vaginitis screening assays that uses the starlet and to prepare the plates and to extract the DNA and prepare the plate. And a CFX biorad is used for amplification. And similar to Aptima, the assay quantify lactobacillus, Gardnerella, and Atopobium. And it use also, it add, on this one, it adds a qualitative detection of Molybunchus. It used a proprietary algorithm to produce quantitative results of BV. The assay also detects Candida albicans, Candida others, and Trichomonas, and produce qualitative results for each of these targets. We designed the study as followed. So for all the specimens were evaluated on the conventional and also on the Aptima, on the molecular testing assays, such as the Aptima, BV, and CV-TV assays. When the discrepancies were noted for BV, the gram smear were re-examined by a senior technologist. And also the proportion of errors were calculated at that point. For the yeast, if there was a discrepancy, we did reculture the conventional swabs. And then after that, if discrepancies remained, or if the gram smear was not available for review, which happened, the second molecular assay, the vaginitis screening assay, was performed on the specimen. And from there, a consensus results we were able to determine a consensus results based on the agreement of at least two methods between the conventional and the two molecular assays. And then we calculate the PPA and the NPA. So we tested 422 specimens. We were aiming for about 100 specimens in each Nugent score categories. We tested 90 specimens for Trichomonas and 242 specimens for Candida. Okay, so here's the results for BV. So on the first pass, where the Aptima BV results were compared to the original Nugent score, we had a good agreement on the positive specimens. However, the assay were overcalling BV in specimens that would have been considered negative by Nugent score. So we did look into these discordance. The discordance between the gram smear and the Aptima results was seen in 82 specimens, which is about 19%. Unfortunately, we didn't have access to all of the gram smear. They were available for only about half of these cases. And of the 42 gram smear that we reviewed, the error of the original interpretation were noted in 25 of them, which is nearly 60%. So if 25 gram smear reported error were made in 422 studied specimen, the proportion of error is about 6%. However, since we could not evaluate 40 gram smear, and if we assume that all those may have errors, the proportion of gram smear interpretation error could be up to 15.4%. And if we had a closer look at those errors, 11 of 16 of these BV positive specimens were initially scored as intermediate. This intermediate category is used in our lab system to indicate an altered vaginal flora that may represent a transitional stage. But it appears that our technologists in our lab were overusing this category when they were unsure of calling BV positive gram smear. So therefore, there was a 64% of errors that were involved the overuse of the intermediate category. So further testing on the BV discording specimens between the Aptima and the conventional method was needed. So we did C-gene, we did apply the second molecular assay, the C-gene Allplex, was performed on these specimens that remained discordant after the gram smear review, and also on those that we did not have the gram smear available. So in both of these groups, the molecular assays testing were concordant in the majority of the sample, and we were able to provide a consensus result. And the most common situation was a BV negative gram smear, which was called BV positive by both of the molecular assays. So after the discrepancies were resolved, the BV assay demonstrated excellent agreement compared to consensus results. Now for the CV-TV assay, when we look at the Candida species group on the CV-TV assay, and when the results were compared to yeast culture, we had a relatively good agreement that was seen. However, we did have 18 specimens that were Aptima positive and culture negative. So we did reculture these specimens, and they remained the same. So reculturing was not a good way of resolving the discrepancies. So we did run these specimens on the Allplex vaginitis assay, and of these 18 discordant, we had 11 that were found to be positive by the Allplex assay. And the CT value of these specimens were between 29 to 38, which suggested a low yeast abundance in this specimen, and probably that's why it was not picked up by culture. 7 Aptima results were not corroborated by culture and the Allplex specimens. So after the discrepancies were resolved, the Candida species group target on the Aptima assay did demonstrate an excellent agreement compared to the consensus result. Now, if we interrogate the Candida glabrata target on the CV-TV assay, when we compare to the yeast culture results, an excellent agreement was seen right away. We only had 2 specimens that were Aptima positive and culture negative. And when we did reculture these specimens, they remained negative, so that was not very useful. And so both of these specimens were run on the second molecular assay, and they were both found to be negative on the Allplex. So it didn't change the PPA on the NPA, but it was already pretty good from the start. Lastly, we saw an excellent, perfect correlation between the TV target on the CV-TV and to the Aptima TV assay. But since both of these assays were produced by Hologic, so we did, as an additional measure, we ran those on the vaginitis screening assay from the Allplex from C-gene, and they were all confirmed to be TV positive or TV negative. So I would like to highlight a few things. First, this was a retrospective study, so the results could not be correlated clinically. But we did demonstrate that the BV assay provide more accurate result than the conventional testing in this study. There are some limitations that should be taken into consideration, though. For example, there's differences in sampling. The BV test was done on a multi-test swab and gram smear on the e-swab. So it's technically 2 different specimens. They were, although collected on the same patient at the same time. Additionally, not all gram smear were available for review, which may also influence the results. Nugent score interpretation may also account for some of this variability, since the gram smear interpretation requires a highly trained technologist, and likely due to uncertainty, the specimens were being over-reported as intermediate, where in reality they were BV positive. Another factor is that the Allplex and the Aptima assays use identical targets to detect BV. So since the Nugent score includes Mollibuncus, which is not included in the Aptima assay, this would could account for differences. Also, other bacteria, such as the anaerobes, can have a similar appearance to Gardnerella, and the results it could result in a high Nugent score, which again would not be detected by the optimal assay. For CVTV, we did saw that the assay was more sensitive for yeast than culture. About 8% of our specimens were CV positive, but culture negative. Culture is known to detect yeast colonization in about 30% of women, and since the molecular assay seems to be a little bit more sensitive than culture, we think a comment is required to help the providers to interpret the positive results for yeast. I want to talk a little bit briefly about the implementation process.
To be aware of the time. Maybe you could wrap it up.
It's my last slide.
Okay, that's
Okay, we did implement this molecular assay. It was a staged process that took about 18 months. The first 12 months was spent preparing the validation protocol, collecting specimens, and performing the validation study. And once we were happy with the results, we did spend 1 month giving educational talk to providers and train the staff, and we had a soft launch with a grace period of 1 month. And then after that, we did apply rejection criteria and continue educated providers to submit the right sample. So we had to switch swab, which was definitely a challenge, and it requires time for full conversion, but we did think that switching to molecular tests for vaginitis, it did improve the efficiency and the quality in our lab system, and it did help to mitigate our staffing shortage. So in summary, there's an educational component to implement this test, mainly due to a change in the collection device for the clinic. There is also an increase in sensitivity for yeast, and we have now universal testing for Trichomonas with this test. There are some unanswered questions, though, that we hope to resolve in the second phase of our study. For example, we don't know the clinical impact yet on this increased proportion of CV positive specimen as well as the multi-positive specimens. We will also like to assess the feasibility of patient self-collecting specimens. For more detail, our study has been accepted for publication in the ECCMID, so you will be able to see that soon. Okay, I'd like to thank all the people that work on this project at both sites, and and thank you for your attention. I'll be happy to answer questions.
Thank you very much, and for sticking despite the technical problems. Since we are kind of short in time, I would think questions can be asked after the session, and I would like to strictly lead to the next speaker.
Yeah. So let me remind the speakers that they will be down here by the podium after the symposium, and you're very welcome to come down and discuss your problems. So Martin Obermeier is already standing up there, ready to talk. He's a specialist in laboratory medicine and head of the Laboratory of Medical Infectious Disease Center in the fantastic city of Berlin.
Thank you for your nice introduction. So, yes, here are my disclosures, and yes, the Medical Center for Infectious Disease is a private laboratory that is owned by me, so that you know if I'm talking about do more testing. So it's always maybe a bit conflicted, to be honest. So, but I think I can convince you that there is good reason for that. So we see a high incidence of sexually transmitted infections worldwide, and I always find this number, global number, so you know it's estimated cases. 374 million cases of STIs, and here we're talking about chlamydia, gonorrhea, trichomonas, and syphilis infections. I always find it a bit embarrassing to see in adults 15 to 49 years old, we definitely see STIs in older patients also. So just to be aware about that, so it's not restricted to these age groups. But nevertheless, we see a lot of infections, we see a lot of treatment there, and a lot of treatment and a lot of antibiotics always lead to a lot of resistance. So let's start with Neisseria gonorrhea. So this is data from my laboratory, where you also see that a lot of things changed over the time. When we look back in time, so then testing was mainly driven by symptomatic patients, where we nowadays switch over more and more to testing asymptomatic patients. This testing is mostly performed by nucleic acid amplification technologies and is more and more increasing. What is the reasons for that? So I think it's a lot about awareness about sexually transmitted infections, which is good, and also about pre-exposure prophylaxis in MSM or other sex-positive communities that lead to these increased numbers. So pre-exposure prophylaxis for HIV, people take with a high risk of acquiring STIs, taking Truvada and FTC, so 2 drugs for preventing to get infected for HIV. One recommendation is that they get every 3 months tested for an STI, so syphilis, chlamydia, and Neisseria. So that also increases the number, but it also increases the number of patients tested with no symptoms. What is our problem with that? So when we look at the number of nucleic acid amplification tests done in my laboratory in 2022, we performed something around 26,000 tests for Neisseria gonorrhea with 2,700 positive results. We always counsel them, or we counsel the physicians to also send us samples for culturing those Neisseria, because we want to know what is the antimicrobial resistance pattern we see there, and also to help them really in guiding their treatment. So really to see how do they fare, is it still working? Is it possible to maybe switch the treatment or to use something else? So if you compare that now, so 2,700 positive samples, but overall only something about 90 samples sent in for culture. And only 37 of them were tested positive in the end, and where we could do antimicrobial resistance. So the perspective, at least in my laboratory, is we don't know so much about that. So let's take a look at the more global perspective. Here, what we see in our laboratory is that we see a huge amount of ciprofloxacin resistance. We also see quite a substantial amount of azithromycin resistance, but at the moment, no cefixime or ceftriaxone resistance. But what is really when we're looking into, yes, all over Germany, so stepping up from one laboratory to let's look at the rest of Germany. So at the Robert Koch Institute, there is the GeoSurf AMR. So it's setting up that they are collecting all the samples that or they are trying to collect as many samples. They started in 2013, and it took until 2020 until they are now reaching that point where they are having a good contact to a lot of laboratories and isolates are sending for them. It changed also because since March 2020 there is a mandatory notification for Neisseria gonorrhea with reduced susceptibility, but remember, only a very, very small fraction of samples we have this data. So that's also a problem. How representative is that number, what we see there? So, and it's also quite a pre-selection bias we have there. So mostly samples from patients that have treatment failure are sent to getting cultured and tested then. So there is a permanent establishment of the extended phenotypic and genotypic Neisseria gonorrhea antimicrobial resistance surveillance now at the Robert Koch Institute. In addition, something changed in so quite short ago. So there is also for the infection prevention law in Germany now anonymized laboratory-based reporting especially for azithromycin and cefixime and ceftriaxone. When we look at the data, what we see, and I really want to thank Regina Selb for giving me the data already for last year. They are not published by now directly from the Robert Koch Institute, but they allowed me to show the data here. So you see quite a substantial number of ciprofloxacin resistance. Yes, penicillin resistance, there was no reporting in 2021, so don't get the data wrong here. But you see a really increasing number of resistance isolates for azithromycin and a small number of cefixime and a very, very small number of ceftriaxone resistant isolates. What is even more important, if we look at azithromycin, then the minimum inhibitory concentration for azithromycin is increasing over the years. So if you see these bars for 2020, you see much more of these higher level resistance, and the ECOF for azithromycin, so the epidemiological based cutoff is 1. So we now see more samples with an MIC over this ECOF. If we now look at the global scale, so ciprofloxacin resistance is very, very common. We don't have reporting from every country, but we see at least from Asia, Eastern Asia, that there is an extremely high amount of ciprofloxacin resistance. But we also see ciprofloxacin resistance in many other countries. Nevertheless, so the range in, yes, Germany and most parts of the Europe, it's still somewhere between 30 and 70%. In some countries, more near to 30%. But overall, there is quite a high resistance rate. If we look at azithromycin, it looks a bit nicer, but also there is already quite a substantial rate of resistance, somewhere between 5 and 30% in the Eastern Asian countries, and also quite high resistance rates in all over Europe. Remember that if you have a resistance rate above 5%, it is not recommended anymore as some kind of initial treatment without knowing any data about the resistance you see. When we look at cefixime, so not so much data available all over the globe, but if you look at Europe and Northern America, also it is starting to become more resistant isolates or detection of more resistant isolates. But if we then now look to ceftriaxone, and there are a bit more data, you already see, especially in the Eastern Asian region, a bit more of resistance showing up. And yes, I think it's more a question of when these isolates or when these strains are really going on the journey around the world, and we will see more of the ceftriaxone resistance. The treatment recommendations at the moment, so if you look at the WHO, some countries are already reacting, and I'm not sure if it's always the best way. So the recommendation from the WHO is 250 milligrams intramuscular plus a single dose of azithromycin. The European guidelines are for 1 gram intramuscularly as a single dose together with 2 grams of azithromycin, or 1 gram of ceftriaxone intramuscular as a single dose. While the German guidelines are, let's say, more flexible, and that is also used quite much. So a lot of the physicians already give 2 grams of ceftriaxone plus 1.5 gram of azithromycin as a single dose. And the ceftriaxone is either given intramuscularly or intravenous. As you see in the German guideline, there is also still cefixime orally as a single dose or 2 times 400 milligram with a dosing interval. So, but you see always in combination, only this one part of the guideline, whereas there's ceftriaxone alone, always in combination with azithromycin, which, you know, is somehow resembles, or it has the idea of what we do in tuberculosis or in HIV, so combining drugs to make the resistance barrier for the isolate higher. But hold that thought for later on, because we know that there could be interactions. We already know quite good the molecular determinants of resistance. So if you look at this very, very busy slide, and I just invite you to read this article, it's fantastic. So it's you learn so much about the molecular determinants of resistance here. And but we know that for example mutations in the PAR-C gene and the Gerard gene are relevant for ciprofloxacin resistance. We know the mutations in 23S ribosomal RNA SNPs that are important for azithromycin. So we can really go over to do resistance testing by means of molecular diagnostics, so genotypic, in a very easy way, not only using some sequencing approach. I will also invite you to look at that poster that was presented by Özlem Yildirim from my laboratory that made a master thesis about the multiplex PCR testing for genotypic resistance for Neisseria gonorrhea. Not only she presented data on that, there were different other sessions that are very interesting, and I think you can look at them using the online tools. So also from the ECCMID program, a lot of other sessions were around this topic. And we have all the tools there to go for genotypic resistance testing and getting more information about that. If you look for something like doing your typing your MLST or getting information about the resistance, there is for example NG-star, but there are also others in the internet available, and there are good publications and good tools already there where you can simply paste in your sequences. They even provide you with the primers you need to set up your sequencing approach. So everything is there to do this and to get better genotypic data. But you know, I'm still very, very interested in the phenotypic data, but the genotypic data is simply much easier to get. So there will be new antibiotics. We're talking about things like gepotidacin, for example. But we already know the resistance-relevant mutations for these drugs. They might be coming up more, so we need more surveillance in that, and we need, I think, clinical studies or data collections like Carsten presented in his talk. So, but nevertheless, so we already can start and monitor also for these mutants. There will be soliflodacin, for example, where we already also know what mechanisms could happen, or what mutations we could see, and we could also screen for those and sequence that. But we can also screen, and this was an eFurch poster presented here, I think you can also get it via the online platform, showing that you can also look at the other Neisseria, the non-gonococcal Neisseria, and see what resistance development is there and what mutations you can expect here in that case in the GRB gene. Let's switch over to another bug. So going away from Neisseria gonorrhea, we have also other STIs like Mycoplasma genitalium, where we see a huge problem in antimicrobial resistance. The number of tests performed for Mycoplasma genitalium it's a bit more like, where's the interest at the moment? So it's always the discussion. So when we started with all those things about PrEP, pre-exposure prophylaxis, testing a lot more of asymptomatic patients, everybody was saying, yes, then we test also Mycoplasma genitalium with that. Seeing that we've seen a lot of cases of that the correlation to, yes, really symptoms is not really good. Is it really, in which cases does it make symptoms? So now everything switched back again to symptomatic testing. And so that's the reason why the numbers decreased, and not only the reason that we see in the beginning of 2020 that during the start of the corona pandemic, so we've seen a really drop in testing, but it's keeping continuous. But when you see the rates of positivity grow higher and higher, they are now reaching, I think, some kind of plateau, but 20% positivity rate is quite high. We're looking here mainly at men who have sex with men, so, and also here in that case mainly on persons with symptoms that in very often have already been tested for Neisseria and chlamydia before that. So the molecular determinants of Mycoplasma genitalium resistance are also quite well known. There are mutations in the 23S ribosomal RNA that are associated with the resistance against azithromycin and yosomycin. Pristinomycin usually is still an option, but yes, it's an option in a way that you can do it if you can get pristinomycin, which is quite problematic, at least in Germany, as far as I know. Also in other European countries, it's not so easy to get access to pristinomycin. So you always have to think about, are there other options? Yes, there are. So you can treat with moxifloxacin, but we also are aware of mutations in the PAR-C gene and also in the GER-A gene that are associated with resistance. And yes, there are also mutations known that are associated with resistance against doxycycline. So these are in the 16S ribosomal RNA, so one mutation that is closely correlated with that. So when we looked in our MSM population, so that were Mycoplasma genitalium positive, so we did a test for azithromycin and moxifloxacin for genotypic resistance. And what we've seen is that we already have in this population a resistance rate of 83% resistance against azithromycin. So not the small part of the pie is the resistance, so but it's really the largest part. With moxifloxacin, I think the 20.6% are overestimated because some of the assays have mutations in it where the correlation is not so clear, to be honest, and you could still try to use moxifloxacin and could have treatment success, which is, I think, especially in those patients that usually they have combined resistance against azithromycin and moxifloxacin, and when you don't have access to pristinomycin immediately, you can think about even still try it. So, but it's more like a thing you can combine it with doxycycline. That, but that's a different topic. So where it's more about how to treat Mycoplasma genitalium. Macrolide resistance is not only high in MSM in Berlin, so but it's also increasing in many different other parts of Europe, especially also the Scandinavian countries have already quite high rate of macrolide resistance, but also in the other European countries you see quite a substantial number, and these are data that have been collected by the ECDC. So what are the reasons for the high resistance rate? And now I'm coming back also to the treatment of Neisseria gonorrhea. When we look, we have a quite substantial rate of patients with Neisseria gonorrhea that get also treated with a single shot of azithromycin. Then we have those patients that have, yes, co-infection between Neisseria. Yes. Thank you. We have those patients that have, here it's 4 minutes, so that was, I'm confused. So, no, but nevertheless, so you have those patients that get their single shot of azithromycin, and that's quite a risk for getting macrolide resistance Mycoplasma genitalium. So yes, while I'm thinking you shouldn't screen in asymptomatic patients for Mycoplasma genitalium, but look at Mycoplasma genitalium if you have somebody that is Neisseria gonorrhea positive and you want to treat them with a combination of azithromycin. Just one short look at Chlamydia trachomatis. So there's no real resistance problem by now. So, but there is lymphogranuloma venereum out there, and I really, yes, want you to think about looking into, especially in cases where you find in symptomatic patients Chlamydia trachomatis in the anorectal region, and they have a proctitis with chlamydia. Really look into lymphogranuloma venereum because there is really a longer treatment required compared to 1 week of treatment, which you would usually do. It is 3 weeks for patients that are infected with the L1 to L3 strains for Chlamydia trachomatis. It's an increasing problem also in Europe. So lymphogranuloma venereum, when you look at the UK, Belgium, France, you always see increasing rates. And yes, we can say that's the same in Berlin. And also we've seen quite a drop in during the Corona phase. Now we're up at the numbers that we've seen in 2019. Just one reminder, so we will see maybe some more selective pressure using doxycycline because there will be more and more upcoming doxy-PEP, so post-exposure prophylaxis with doxycycline. There are good studies out there that you really can reduce the probability of an STI diagnosis with that. So doxy-PEP is a strategy where you use 200 milligrams of doxycycline within 72 hours of condom-less sex. But it's, you know, it's somewhat throwing even more doxycycline into the population. And while I think it's a valid strategy, it has to be combined with the same amount of surveillance for antimicrobial resistance. So antimicrobial resistance is an increasing problem in STIs. More surveillance is needed for all of the STIs, not only for Neisseria gonorrhea. I think it's very important there, but also for the others. Central collection of data and samples is really essential. So we have to know what's going on around the world, and that is really important. Clinicians need to send more samples for culture and AMR testing, and I know it's sometimes problematic because the patient is there, you have the nut result, you want to start immediately your treatment. You don't want to take another sample. It's complicated and a lot of things, but we really need the data. Molecular diagnostics is important, and we can do a lot with lots of surveillance with molecular diagnostics, but I think you will still need the classical microbiology. It's not that complicated. It's a bit labor intensive, but I think you will still need the data, and new treatment approaches are needed. I would like to thank you for your attention, and especially my colleagues from the Medical Center of Infectious Diseases in Berlin, of whom are some sitting here also in the room. And I want also especially to thank Regina Selb from the Robert Koch Institute. Thank you.
Okay, while Jan moves up here, we'll take a single question from the audience. Thank you, Martin, for a very fine presentation. So let me just, you talked about LGV here. So where are we with commercial LGV testing?
Yeah, I think there are some commercial assays out there for LGV testing. So this is true. But I think we need more, for lymphogranuloma venereum, we need more testing. So it's, I think it's, you really should think about some kind of reflex test for that. I think that's really an important thing. So it would be much less labor intensive than picking up those samples out of there. And so I think really reflex testing for that would be great. Thank you.
I think this is a message to the large providers of STD that they need to have a LGV test as part of their panel. Yeah. Welcome to Jørgen Skov. He's a consultant physician about 3 metro stations away from here at the State Serum Institute. He has a lifelong interest in STD, especially Mycoplasma genitalium, and in the more recent years, the vaginal microbiome. Welcome, Jørgen.
Thank you. Before we start, here are my disclosures. And the topics for today is first to give you a brief introduction to Mycoplasma genitalium. I think you've already been a little bit introduced to it, but I'll spend some time discussing diagnostics. And then I'll go through the NAME study, the Nordic Aptima Mycoplasma genitalium evaluation study, which is a study that was done when the TMA test was introduced in Europe. And the reason for mentioning that relatively old study is that this is a basis for our recent study, looking at what happens with the patients that are diagnosed with a TMA but are negative with our conventional PCR methods. Are those findings really clinically relevant? And finally, I will spend some time discussing antimicrobial resistance in MG and something about the drugs we have available as future treatment options. So Mycoplasma genitalium was isolated back in 1980 from 2 men with non-gonococcal urethritis by this guy, David Taylor Robinson. And he's here holding a squash with the same shape as a Mycoplasma genitalium cell, which is mediating the attachment to eukaryotic cells with a specialized tip structure. Detection of MG relies 100% on nucleic acid amplification test because culture takes several months and serology is not sensitive or specific enough. And today I'm sure that most of you would agree that it is an established cause of STIs. And in most settings, it's only second to chlamydia trachomatis in prevalence, and in some settings, even higher than chlamydia trachomatis. One of the difficulties working with mycoplasmas or treating mycoplasmas is that they lack a cell wall, which means that our conventional beta-lactam antibiotics have no influence on them at all. And this leaves us with very few antimicrobial classes that we can use for treatment. So since we need NATs for detection of MG, we had the first NAT test published in 1991. And we have had CE-marked PCR-based tests available in Europe for approximately 15 years, but few of them have been thoroughly validated, and mostly they have been low throughput and not automated. So the development of high throughput NATs has been relatively slow until recent years, and I think some of that is because most of the major diagnostic providers are US-based, and since the US CDC has been very slow in deciding what to do with Mycoplasma genitalium, they haven't had the incentive to really go into assay development. But now at least there are 3 current FDA-approved assays which allow high throughput detection of Mycoplasma genitalium NAT. The first was the Hologic Aptima assay, which targets the 23S ribosomal RNA. The second is the Roche Cobas TVMJ test, which applies a dual target mycoplasma adhesin gene. And the final and most recent is the Abbott Alinity, which is a reverse transcriptase PCR, which also targets the ribosomal RNA. There are also a few other CE-marked tests, and some of them can also detect macrolide resistance, and a few of them also fluoroquinolone resistance. But to the Nordic Aptima Mycoplasma genitalium evaluation study, for that study we aimed to clinically and analytically evaluate the Aptima assay, which was new at that point, on the Panther instrument, and to determine the true prevalence of MG and CTNG in an unselected STD population back in 2016. And we also wanted to look at the prevalence of resistance in the 3 Nordic countries. And this was published in a paper by Magnus Junimo back in 1918. The study applied 2 sorts of testing. We took samples in Aptima transport medium for Aptima Combo 2 assay, and then we used the CE-marked Aptima MG assay targeting the 16S RNA, and then we had an alternative research use only TMA assay, the Alt-TMA1 assay targeting another region of the 16S ribosomal RNA. And the reference assay we used was the MGP-based Tachman PCR that I developed back in 2004, which we had used for a lot of clinical studies over the time and which has been widely accepted by other researchers. We did resistance detection with MRM detection, with SNP detection, with pyromark sequencing, and we did quinolone resistance testing with Sanger sequencing. What we found was that there's a large variation in the prevalence between sites. You can see in Copenhagen, we had more chlamydia than Mycoplasma genitalium, but a lot of Neisseria gonorrhea, and that was because the general physicians admitted these patients for treatment to the STD clinic. Similar in Norway, they had more chlamydia than Mycoplasma genitalium, but in Örebro, in Sweden, they had more MG than chlamydia actually. So the Aptima CE-marked assay had an extremely good sensitivity and specificity, meaning that also the predictive values were very high. But to my frustration, our Mycoplasma genitalium PCR assay detected only 76% of the positive patients. This is on a patient level. But the good thing was that it had a good specificity, but the predictive values were somewhat lower than the Aptima assay. We also found that the resistance pattern was different between the Nordic countries, with a lot of macrolide resistance in Denmark and Norway, and very little macrolide resistance in Sweden. And the reason for that is probably that Sweden has been using doxycycline for treatment of chlamydia infections throughout the history, whereas Denmark and Norway switched to azithromycin very early on. Fluoroquinolone resistance was still at a relatively low level, again, slightly higher in Sweden. So I skipped this one. So the conclusion of the NAME study was that this was actually a very high-performing assay. It was easy to use, and unfortunately, I had to admit that my assay missed 20% of the positive patients at least. So this means that what we have been published over the years was probably underestimates. And we also found that macrolide resistance, which we already knew, was widespread in both Denmark and Norway, but not so much in Sweden. We also found that there was a relatively low level of moxifloxacin resistance. But what to do with those patients that are positive with the TMA assay, but negative with the conventional PCR assay? Does that really mean anything clinically? So we took a look at the 1,245 individuals that were included in the Danish part of the NAME study. That was about 500 women and 750 men. And among the men, 1/3 were MSM. We had 112 MG-infected patients, slightly higher proportion among women than in men. And when we looked at the sensitivity of the PCR assay on a specimen level, it went all the way down to 65% on the specimen level. So that meant that we had 55 specimens from 48 individuals that were missed by the PCR, and 28% of the individuals that were tested were diagnosed only by the TMA. So what were those patients, and how did they match with our expectations regarding symptoms and other things? So the first thing we did was to look at the proportion of symptomatic patients among those that were positive, and it was about 50% of the women that were I don't know what happened to the ranges here, but approximately 50% of the individuals were symptomatic among the women, and slightly more symptomatic patients among the men. When we looked at those with concordant results, that is a TMA positive together with a PCR positive, the distribution was the same. Slightly more symptomatic patients among the women with a TMA only positive. So definitely we couldn't say that these were just irrelevant infections. We had the same distribution in the two populations. It was a little bit the opposite way in the men. There were more symptomatic patients in the concordant group than in the discordant group, but especially in the urethral group, there was more asymptomatic in the TMA-only positives. And that positivity in the male group was due to a higher proportion of men in men who have sex with men. So as you can see here in the concordant group, the men who have sex with women are mostly concordant, whereas in the discordant group, the MSM group is more prevalent. So this indicated that the sensitivity, increased sensitivity of the TMA really resulted in diagnosis of more M. genitalium infected individuals who had clinically relevant symptoms. And for some reasons, we didn't see as many concordant samples among MSM, so they tended to be more often false negative. But it wasn't so that the proportion of symptoms was different in the MSM between the concordant and the PCR false negative, so it wasn't a reflection of asymptomatic infections. But this raises some concerns because now we have maybe 25 to 30% of the MG infected individuals who we cannot do a PCR-based macrolide resistance typing using our current PCR-based typing system. So the question is, what should we do with these patients? And I don't think I have a good answer to that. I think it will depend on the local prevalence of resistance in your population. But apparently Hologic is making assay-specific reagents available soon in the US, and that is based on a reverse transcriptase PCR running on the Fusion platform. And the performance data have not yet been published, so you have to wait for that. Unfortunately, I'm not sure it's going to be available in Europe in the short term. So for management of patients, I think it's very important that we have the result of resistance mutations detection, especially for macrolides, because we need to shorten the duration of infectiousness so that we don't spread the infection in the community. And we also need to limit the use of moxifloxacin, so we cannot just give everybody moxifloxacin. And this is because moxifloxacin has a warning label saying that it should only be used where you can't use anything else, because there are rare but severe side effects with moxifloxacin, so you have to limit the use as much as possible. In my opinion, there's no indication for quinolone resistance detection up front, first line, because the detection of QRAMs, the quinolone resistant associated mutations, are a relatively poor predictor of treatment failure. and we don't have good alternatives to moxifloxacin at the moment. On the other hand, I think it's very important that we do moxifloxacin resistance testing after failure in order to discriminate between reinfection and resistance. So resistance is becoming more and more of a problem. This is a map showing the dual resistance worldwide, and you can see the darker areas here in the US and in Asia and Japan. And a publication mentioned that there were 88% dual resistance in China, so a huge problem in that region. The third lines available drug that we have now are pristinamycin. It's a complicated dosage with 4 times daily dosing, and it only has a 75% cure rate. The good thing is that it's considered safe in pregnancy, so if you have a macrolide-resistant infection, then it's possible to treat the pregnant woman with pristinamycin. Minocycline, given for 2 weeks, has a 70% cure rate, whereas doxycycline has a 40 to 50% cure rate if it's given in the longer dosage. But as you can see, none of these regimens are really very convincing. So this is the reason for the guidelines saying that you should not test asymptomatic individuals, because you will end up with a lot of asymptomatic individuals that will need treatment with complicated treatment regimens, which are also expensive. And we don't know if we actually do more good than bad by treating all those asymptomatic patients with moxifloxacin. So the alternatives we have that are available are citalfloxacin. It's available in Japan and in Australia. It's more potent than moxifloxacin and can be used to treat some of the QRAM-positive patients. Lefamulin is a new drug that was marketed a couple of years ago, and it has an extremely good in vitro susceptibility. So we all thought that this would be the new wonder drug, but although there's very limited clinical experience, we have to say that it doesn't really fulfill our expectations. We see frequent treatment failures. And more data on that will be presented on the ISS TDR conference in Chicago this July. But I think this points to a question regarding in vitro susceptibility testing versus real clinical testing, that we cannot always extrapolate from the in vitro data to the clinical data. Martin mentioned soliflodacin and gepotidacin. These are on the market or in clinical trials for gonorrhea, but there's nothing known about their clinical efficacy against Mycoplasma genitalium. The MICs look good for soliflodacin and for gepotidacin, but there have been some strains with elevated levels of MIC. Omadacycline is registered in the US, and apparently looking at a relatively small number of isolates, it looked promising, but again, we don't have any clinical experience with it. Eravacycline is available also in the EU, but it needs to be used as an intravenous drug, and the MIC is not as promising as the omadacycline. So in conclusion, I think the CE, IVD, and FDA-approved highly sensitive assays are available, and they should be used. They are much better than our lab-developed test, unfortunately. Previous prevalence studies are therefore slightly underestimated, and apparently the added sensitivity of the Aptima-MG assay is detecting clinically relevant infections. Optimal patient management requires information about resistance markers, and there are several resistance assays available outside of the US and several lab-developed tests, so there's no excuse for not trying, at least in Europe, where you can get away with it. Multi-drug resistance is a real threat, so we only need to test asymptomatic patients, and antimicrobials need to be sourced on a special permit, and this requires specialist physicians to handle these patients, which is expensive and complicated. So we need more clinical trials to expand our antimicrobial toolbox, and we should be aware that in vitro studies are not always predictive of real clinical activity. So in conclusion, I think we have to admit that Mycoplasma genitalium is already the first untreatable STI in some patients. It was a big warning about gonorrhea, but I think Mycoplasma genitalium made it before that. And with that, I would like to acknowledge my co-workers and colleagues and remind you about the ECCMID study group, the chlamydia and mycoplasma study group. Get involved, it's free, and it's a very nice bunch of people. So thank you for your attention.
Thank you very much, Jørgen. We are pretty much 1 minute over time. Is there an audience is there a question from the audience?
Yes, I have a question. Thank you, Jørgen. Ronayers from the Netherlands. In our country, it's advised that to only test for Mycoplasma genitalium when either a man with urethritis or when CT/NG is tested and remain negative and ongoing complaints. But if chlamydia or Neisseria is testing positive, would you recommend to reflex test Mycoplasma genitalium? Do the reflex testing for Mycoplasma?
I think it's problematic to call the patient again if you require a negative CT/NG test before you test for Mycoplasma genitalium. So in my opinion, if you have a patient with urethritis and symptoms, I think it's relevant to test upfront, but I know that can also be an economical decision. You could, of course, if the lab allows it, have a reflex testing of the CT/NG negatives, of course. Yeah.
I actually meant that when chlamydia or Neisseria is testing positive, would you directly recommend to reflex test for Mycoplasma? Because an STI is proven.
If they are positive, I think you should start treating those infections first.
Yeah, obviously, but don't you want to know that if Mycoplasma is present also?
No.
No? Okay,
no.
Thanks.
Okay, thank you very much. If there are anybody...
So at least in our population, I'm Mario Parcina from Bonn University, at least in our population you get normally everything as a package, yeah? You get chlamydia, you get gonococci, and you get MG, if you are lucky. So we basically test everything and treat accordingly what we find, yeah? So this is our experience, what we have.
Yeah.
Thank you.
Let me answer that. I think, like we have antibiotic stewardship, we also need diagnostic stewardship in what we're doing. And Jørgen was talking about what I would call diagnostic stewardship. So thanks to the audience, thanks to the speakers, thanks to Hologic for organizing this. I think we're all going home with increased knowledge on STIs and especially on PV. Thank you very much for today.